It's now my privilege to invite Dr. Leonardo Kapural to present the Neurosurgery Pain Article of the Year, comparison of 10 kilohertz high-frequency and traditional low-frequency spinal cord stimulation in the treatment of chronic back and leg pain, 24-month results from a multicenter randomized pivotal trial. Dr. Kapural.
Thank you very much. It's a great recognition, me as an anesthesiologist, to get the such a nice award from neurosurgeons. So it's phenomenal time to be in neuromodulation, especially in spinal cord stimulation for chronic pain. This is a summary statement from the last issue of the Spine that was 2 months ago, and talking about the new developments and new waveforms that moved forward spinal cord stimulation for especially back and leg pain into totally new era. And I think we were on top of the things with the 10 kilohertz spinal cord stimulation modality, and I'll explain you this in a second. So interestingly enough, for back and leg pain, 3 level 1 evidence papers were all published in neurosurgery. From Dr. North, who is here in the audience, and he's been a phenomenal mentor over the years for all of us who are involved with this. At that time, comparing the spinal cord stimulation with surgical interventions to Kumar's study, a larger study, and then our study in 2016 that was awarded here, enrolling 200 patients, 100 in each arm, in non-inferiority fashion. So those 3 studies, when you look at the trialing, enrollment, and long-term follow-ups, we didn't have that much of the data on the back pain as we had on the leg pain. I'll give you a little bit details in a second about these numbers. So a little bit about 10 kilohertz. So 10 kilohertz spinal cord stimulation is a paresthesia-free stimulation, which relies on a consistent anatomical placement of the leads, so it has predictable time interval of the placement when it comes to the trialing as well as the implant. It relies on algorithmic evidence-based programming, and initially the first indication was to treat back and leg pain, and this sensor study is all about it. So if you look at the design of the sensor study, it was non-inferiority designed as prescribed by the FDA, where commercially available traditional spinal cord stimulation system, this instance was Boston Scientific system, was compared to the high-frequency spinal cord stimulation system. It was rigorous oversight from the FDA, and it was open to reprogramming to both sides. If you look at the enrollment, these were patients with back pain of more than 5, leg pain more than 5, and the severely disabled with the OSFA scores of more than 41, something typical that you can see in your practice. All of the patients were accounted for when it comes to enrollment, and the primary outcome of the primary endpoint was the composite of the safety and efficacy percentage of those patients with more than 50% of the pain relief. And there were about 43% of them in a traditional arm compared to 81% in a HF10 arm when it comes to the permanent implant subgroup, which is probably what you're most interested in. But even in intention to treat analysis, you can see superiority of the 10 kilohertz spinal cord stimulation compared to the low frequency. So 24 months data was voluntary extension from 12 to 24 months, and we had a nice group of the patients, almost pretty much everyone, that continued to follow up to 24 months. Improvements in the pain scores were again on the side of 10 kilohertz spinal cord stimulation compared to the low frequency for back as well as the leg pain. And if you look at the individual patients, and if you look at the HF10, about 76% of the patients with more than 50% of the pain relief. And when you compare this to the low frequency, you can see that the HF10 or 10 kilohertz stimulation was much better. Same for the leg pain. Again, 73% responder rate versus 49% for the traditional spinal cord stimulation. And again, this is each and every individual patient in this tornado chart shown. And at the end, I just want to focus on this comparison when it comes to the low frequency versus high frequency. What makes things a little bit more complicated is that we always have a very high conversion rate. So most of the patients who were trialed, either you trial low frequency, high frequency, burst, any kind of modality of the spinal cord stimulation, end up having an implant. Over 80% of the patients respond within that first week to the spinal cord stimulation of any kind. What happens later on is the key issue. So if you look at the traditional spinal cord stimulation studies with low frequencies, you can see there is attrition that happens over the first 3 to 6 months, and sort of they maintain it at 50-50 range, or 50, what we call about 50% of the patients have more than 50% of the pain relief club. Again, HF10, when compared to low frequency, was much better over the time. Even over 2 years' time, improvements were better on the side of the HF10. So to conclude, and I have about 20 seconds to conclude, SENZA clearly was the robust clinical trial. I'm really proud to be part of it. It demonstrated level 1 evidence for both high frequency and low frequency spinal cord stimulation outcomes, and this was it clearly showed the effectiveness of the high frequency therapy when it comes to the back and leg pain. Now, and what we're doing last 2 years, we're looking into the other indications, like upper extremities, peripheral neuropathies, abdominal pain, to see how this therapy will provide long-term effectiveness in those other indications. So these are the SENZA investigators. I thank all of them to assist in this very large study, and thank you very much.